Hello. Today I wanted to talk about a couple of things related to police when they encounter suspects that then also become patients. Some questions came up about specifically related to putting patients on hold after an opioid overdose. So that's sort of what prompted this conversation. So let's touch on a few of those points. The first thing to think about, and we talk about this on the fire side of thing at some of our training, that the patient or the suspect always gets a vote. So we have policy, procedure, and protocol that we need to abide by. Uh, let's talk about patients in this case, not suspects, but it applies to both. But patients always get a vote. They can do whatever there is in their own best interest, right? And so this comes up when we take patients to the ER for, say, a mental health problem. They get cleared by the ER. They're back out at the bus stop, and you get called again, right? Both police and fire show up. Now the suspect is saying they have chest pain, right? The ER is saying, well, we just evaluated them for the suicidal ideation, so they're cleared from our perspective, right? The ER's got to make a decision about if they're going to deal with the chest pain thing. So maybe they go back in, right? Maybe the patient complaint of suicidal ideation was cleared. They go back to the bus stop and now they complain of suicidal ideation again. And again, the ER is going to say, no, we just cleared them from that, right? So there's this game, and then EMS ends up in the middle, right? So this is a pain. They're frustrating calls. They're going to continue. There's no shortage of patients with mental health problems, with chemical dependency issues. Those often overlap. This is going to continue, and we have to do the best we can in these situations. And I don't have a perfect answer for what to do in all of these situations. We're trying to do what's best for the patient. But again, I think letting go of the fact, in some ways, to help with the frustration, letting go of the fact that we can control the patient. We can't, right? So again, we have policy, procedure, and protocol. They have nothing. They only have their best interest in mind, and that's it. And that can change on a moment's notice. In the same way, when you're with suspects, they seem nice and calm, and the next thing you know, now they're fighting, right? They do whatever they want, whenever they want, and we have to adjust to that. So we're always a little bit on the reactionary side, and there's not a solution for that besides just trying to do the best we can. So they always get a vote, right? So something else about going to the ER and dealing with patients like this, and we're going to get into opioid overdose specifically, but understand the downstream effects or the downstream consequences. I've read this somewhere, I heard this, something about understanding the whip. For like CEOs of a company, when they crack a whip and they make a decision at the very top, at the very end of the whip is the person at the very bottom end of the food chain, or the very bottom end of whatever the command structure, who has to deal with that thing that was set in motion by somebody way up the chain, right? So understanding what you're setting in motion matters, right? So if you say somebody's going to go to the ER, right, what's going to happen at the ER? And we'll talk about that. But I guess understanding those decisions and downstream, and we talk about this a lot on the fire side when they're talking with patients, a patient, whatever their complaint is, they want to go to the ER for something, trying to give the medics some language to talk about what is this actually going to look like when you get to the ER. Are you going to see this person? Are you going to see that person? You're going to see this specialist? What are they actually going to do for you? What are they capable of doing for you? Right? A good example, I see patients all the time who are suicidal and they hate their group home, so they come to the ER. Right? The group home may or may not take them back, but the patient's like, I'm not going back. If I go back, I'll kill myself. And they come to me in the middle of the night. I've never gotten anybody to a new group home in the middle of the night. Like, that doesn't happen. I can't make that happen. So you might be very unhappy with your group home, but you're at least, and you refuse to go back, you're at least sticking around to the day shift where somebody can try to sort that out, because I don't have the resources in the middle of the night to make you be able to switch your group home, right? There's too many things happening. So that's not a realistic expectation. Patients have it, but it's not realistic. So helping them understand what realistically can happen is a lot of my job in the ER in the middle of the night. So the more you understand about the downstream consequences, I think it's helpful in terms of making decisions. Another way to think about it, like just as an example, if you go hands-on with somebody, you never know where that ends, right? We assume when we have to go hands-on with someone, and not related to a medical thing, but with a suspect, when you go hands-on, you assume that you're going to get that person in cuffs. That's probably where it's going. It will eventually happen, but how many steps to get there? Are they going to, is one officer going to be enough? Is it going to take two? Is it going to turn into an all-out brawl and you're calling for backup? And now there's a huge fight going on, right? So understanding, once you put something in motion, where does that thing end and how is that going to play out? And we can't always predict that. So there's always a little bit of an unknown. We think things are going to go a certain way, but that doesn't always happen. So specifically as it relates to holds for opioid overdose, we're going to assume that we had sort of textbook opioid overdose. We're begging or breathing for the patient because that's the thing that matters most anytime somebody's not breathing. Narcan is a tool to be used in conjunction with that, but spraying Narcan to someone nose while they don't breathe for 2 minutes doesn't do the patient any good, right? So if somebody's not breathing And it doesn't matter whether it's opioid, benzos, alcohol, some cocktail of whatever it is that they took. If they're not breathing well, we need to breathe for them. That's number one. You have to breathe for them. Put the pulse ox on, see what their oxygen saturation is. Once they're breathing and you have a decent, or we're breathing for them and they have a decent oxygen saturation, the whole thing can slow down. And this happened when I was in the ER at Hennepin. Somebody gets dropped off in triage, they get rushed back to the stay room, and the young resident wants to just shove a breathing tube in. I'm like, okay, let's slow down a second. Okay, they have a pulse. We can start breathing for them. Their saturation is 100%. Right? Everybody take a breath. We don't have to do anything crazy with a person who has a pulse and an oxygenation of 100%. We can decide what we want to do from there, right? So it slows the whole thing down. So get some decent vitals, take a breath, and decide what you want to do. Maybe you want to shove the whole Narcan up their nose, and they're going to wake up pretty fast. Maybe you want to wait for fire to get there to do a little baby dose of IV Narcan. They're both options, and I can't tell you what to do on every situation. But once we have good vitals on people, everything can slow down a little bit, right? So let's assume we had an opioid overdose. We were breathing for them. They got Narcan. They woke up. They are coherent. Right? Now what? Do they need to go on a hold and go to the ER? That has traditionally been what we've done in Hennepin County, and this has been with myself and the medical directors from the other EMS agencies in Hennepin County, that yes, put them on a hold, take them to the ER. Granted, that's not a one-size-fits-all thing. I would say the default should be, yes, they should probably go to the ER. However, like since we've done this now going on, I don't know how many years that I've been doing this, things have changed a bit, so the observation period has gotten shorter. Lots of ERs will kick people out pretty quickly. There's less tendency to hold people for very long, and I don't know what the current plan is at either Methodist or Southdale or Hennepin, like how long they're holding people. I don't actually see a ton of opioid overdose in the ER where I work, so I don't know if there's a set protocol per se of 2 hours or 4 hours. I know it's been getting shorter over the years. So I would say the default is still yes, try to get the patient to go to the ER, and we'll talk about what are possibilities there. However, I would not put somebody on a hold and fight them to the ER, right? If you just put them on a hold and they're like, yeah, I'll go, and they're cooperative, fine. If you can verbally convince them to go, yeah, fine, right? So you have your command presence, verbal judo, right? And then we get around this restraint, or use of force continuum here. And now we're restraints and sedation to fight them to go to the ER when they were perfectly coherent when they woke up, right? That's probably a bad idea, because this is going to lead to more potential risk. So the juice is not worth the squeeze. If we're doing this for a simple opioid overdose, it's probably not worth it. So I think it would be rare cases where we're actually going to do that, right? Some things to keep in mind, though, when you're making this decision: are they coherent? Are they alone? Are they safe? I think I spelled coherent wrong. Whoops, that's probably an E there. So keep those things in mind. And I don't have an exact answer, right? If they're at home alone in a warm house, great. If they're out on the street and it's cold, maybe they're not safe. Do they have somebody with them, right? So, and I don't have an exact answer. Ideally, in a house, warm, safe with other people would be better than alone, cold out on the street, right? But again, I don't have an exact formula for this. But keep those things in mind when we're considering what to do with these folks. But again, if we can convince them to go, that's great. If we're going to fight them to go, that's a bad idea. The juice just isn't worth the squeeze over here. So what may happen in the ER? So some possibilities. For some people, it's a wake-up call. Maybe they've been using it for a while, like, holy smokes, I just ended up in the ER. I almost died, right? And it's a thing that turns their life around. It's a thing that wakes them up to say, like, hey, I need to make some changes, right? It happens. So they get prolonged observation in the ER. We don't know what people took. There's fentanyl and everything. There's other stuff, other type drugs. And some people go into the weeds about what all the other options are, and I don't have the inside scoop on what all these other things are in the drug supply chain. When I think of patients in an overdose of any kind, it's a binary decision for me. If you're down, like as in you're not breathing and you're sedated, you need to at least be breathing and have decent vitals. So you need to come up a little bit, right? We breathe for you, you get some Narcan, right? If you're up and out of control, you need some medicine to come down a little bit. What caused either of those conditions is very irrelevant to me, either in EMS, and it's still kind of irrelevant in the ER, right? If you're out of control, we need to get you under control so you're not hurting yourself or someone else. If you're down and not breathing, you need to be breathing, right? And we have ways to do that. We can BVM, we can breathe for you. Maybe you need an eye gel, maybe you need Narcan, maybe you actually need a breathing tube in the ER because you're so far down and your alcohol is 0.4, right? And you're gonna need a breathing tube to metabolize that all night, right? What you actually took, what your actual level of alcohol is sort of irrelevant. I treat the patient in front of me. If you're up too much, you need to come down. If you're down too much, you need to come up a little bit, right? The nuances of what specific drug does what specific thing doesn't play into that equation very much. And in the ER, we don't have tests for all of the things. We have a urine drug screen. We can figure out some things, but that also doesn't tell you that whatever's in the patient's system is the thing that's causing the issue that's in front of you now. Because if I smoked marijuana yesterday and then today I'm down because I drank a whole handle of vodka, right? My alcohol is 0.4 and I'm down today. You're going to find marijuana in my urine. It's irrelevant to what's going on today, right? So there's not a test to say, oh, right now in your system, it's this thing that's causing this condition. There's no test like that. So, all right. So again, it might be a wake-up call. Might get prolonged observation depending on what's in their system. The benefit of this is if the Narcan wears off before whatever they took wears off. You want to have a prolonged period of observation. And again, I'm not sure what the hospitals are doing. It may vary by the hospital sort of policy. It may vary by the provider who's seeing the patient. Some are more, not cavalier, but I would say some are more cautious. Some are more conservative. Some are going to be like, no, I want to watch him for 4 hours no matter what. Others like, if he's good in 2 hours, get him out of here, right? So depends on how busy the ER is. Like it weighs into people's decisions. Like, God, we're just getting slammed. This person's probably fine today. If there was no patients, it's February and it's freezing cold and there's nobody in the ER because nobody's out doing anything and we have more time, okay, hang out a little bit longer. Right now we're getting jammed and slammed because it's flu season and there's no beds anywhere and we can cut him short a little bit earlier, right? There's lots of things that weigh into that decision. It's not a one size fits all. The patient may get Suboxone in the ER, right, to help get off the opioid abuse train. So that's a possibility. They might get plugged into chemical dependency resources. So get a counseling appointment set up. Like, okay, here's your first prescription for Suboxone. Come back and see us tomorrow. And, we'll set up an appointment for next week and try to help get those things going. Obviously, that happens more during the daytime when there's actually more people in the ER, more resources, social work, chemical dependency counselors. If you come to my ER in Mercy right now in the middle of the night, for a mental health thing, you get a telehealth. You get a Zoom call with a mental health provider because we don't have people overnight. I don't have a social worker overnight. I'm not going to be able to do any of these things for you. I can do Suboxone, but I can't do any more extensive chemical dependency resources like setting up an outpatient appointment or something like that. So, all right. If we're not going to fight people to go, we end up leaving them. Documentation of this is important, right? So on body cam, and the messaging should be the same between police and fire, right? Fire is going to write a chart saying, hey, we talked about this. We talked about the risks. We talked about that the Narcan may wear off sooner than whatever it is that you took, and you're going to be in trouble again. We recommended you come to the ER. We're offering transport to the ER. And the same thing is going to be on the body cam. So the conversations that everyone is having should be on the same page. Like, hey, man, this was a bad overdose. We think you should go to the ER. What if that Narcan wears off? We don't really know what you took. You don't know what you took. You should come to the ER. We're happy to take you to the ER. We're going to take you to the ER. Does that sound good with you? Right, over and over again. So it's multiple times. And it's not performative. We're not doing this just for the sake of the camera and for the documentation. We're doing it because it's good for the patient, right? Again, there are some options. There may be some benefit to the patient with some of these things, right? So it's not like we're making this up and just trying to perform for the camera. That's a secondary benefit that it's recorded because that matters, but it's good care for the patient. So counseling them repeatedly. Hey, there's some risks here. If the Narcan wears off, you don't have anybody with you, right? You don't even know what you took. It's maybe an unknown substance. All right, so we're talking about that with them. Hey, we're happy to take you. We'll give you a ride. We're already here. We can give you a ride, right? So you're doing these things multiple times, so that's all documented well, and hopefully for the good of the patient. So I hope that clears things up a bit. Reach out to me with any questions. Happy to talk more.